What do you think? Should we get going? Can everybody hear me? Good. Well, thank you all for coming. I'm Emanuele. I'm from the Department of Endocrinology. And today we're going to shift gears away from neurology and look at glycemic control in the hospital setting. So to talk on how to manage diabetes, which you're probably all familiar with by this time. First of all, is it a big deal? Yeah, it is. If you look at how big a deal it is, data shows that about 38 to 40% of all hospital admissions are going to have hyperglycemia. Sometimes it's known hyperglycemia, sometimes it's undiagnosed hyperglycemia, but a lot of times it's the new hyperglycemia. They never knew they had hyperglycemia before, but it's picked up with the stress of a hospitalization. It's a particular problem for people coming in with cardiac issues. Data shows, again, about 45% of people with an acute MI are going to have hyperglycemia. So it's now accounting for about 35 to 40% of all hospitalized patients are going to have those high sugars. So you have to know what to deal with them. So first of all, this will be kind of our agenda for the morning. Glycemic goals, achieving those goals, what to do at the time of discharge, and then we'll focus a little bit on the end on special situations. So first of all, glycemic control. What's the blood sugar in the hospital? Well, it's a little bit gentler bar than what we have on the outpatient side. You know, on the outpatient side, we like fasting sugars to be between 70 and 100 and postprandials under 160. But in the hospital, it's a little bit different. In the hospital, and the patients in the ICU, we start insulin drip going and we get insulin going when their sugar hits 180. And the goal is 140 to 180 in general in the ICU. Now on the floor, it's the same, 140 to 180. So we like, again, pre-meal sugars to be closer to that 140 mark. No, and after any time random throughout the day, should never be higher than 180. So patients in the hospital are entitled to run a little bit softer than on the outpatient side. Where do those goals come from? The goals came from all these studies that have been done in the last 15, 20 years, looking at the impact of good glycemic control on mortality, on comorbidities in hospitals and length of stay, et cetera. All these things get better when you get to that goal of 140 to 180. And again, you don't want to focus on all these studies. There's too many out there to go over, but it's pretty consistent throughout the literature that when you have good glycemic control, patients do have better outcomes. Readmission rate goes down, and that's hugely important too. What about hypoglycemia? How come that 140 is so generous? Well, it's that generous because the risk of hypoglycemia is so high in the hospital setting for many reasons that we'll get to. Patients' kidneys often are starting to head south. Okay, kidney function's getting worse. Sometimes they're not eating in the hospital. So there's a lot of reasons why their sugars start to go down. And hypoglycemia is as detrimental as is hyperglycemia. If you look at, again, the data, hypoglycemia and outcomes, inpatient hypoglycemia is a marker for adverse outcomes. The factors that predispose to hypoglycemia are often associated with adverse outcomes like renal disease, liver disease, et cetera, sepsis, all those bad things tend to occur. So it's a Nike-shaped curve when it comes to the glycemic goal. You don't want people to be under 120 because that's where the outcomes and mortality is so much higher. And you don't want them to be too high over here. So that's where this goal kind of 140 to 180 seems to be the sweet spot for people in the hospital. Okay, so if they're higher than 180, do something. If they're running under 140, be cautious. If they're certainly getting under 120, be very cautious. Under 100 gives us sweaty palms. We really worry then about what's going to happen to them. So how are you going to get there? Well, the way you're going to get there is really insulin. Insulin's about the only game in town. It's your best friend for people in the hospital. Insulin is good because, well, it works, and that's good. It can be used if you've got, if you're in end-stage renal disease on dialysis, if you've got liver failure, if your cardiac issues are horrible, you can always use insulin. It's the one drug you can always lean on, no matter how sick that patient is. It can be used with medications, other medications. There's no drug-drug interactions. And there's some interesting beneficial effects of insulin. It enhances endothelial nitric oxide. Now, remember, nitric oxide is a vasodilator. So by increasing endothelial nitric oxide, you're vasodilating, helping the patient to perfuse better. It suppresses free fatty acids, and free fatty acids are a bad guy. They really create the state and worsen the state of insulin resistance. Insulin inhibits pro-inflammatory cytokines and suppresses inflammatory growth factors. So insulin has a lot of very, very good things, a lot of beneficial effects, and it's the drug we lean on in the hospital setting. Insulin vasodilates. It acts as a metabolic modulator. It enhances cell survival, restrains platelets. They're not going to hyperclot, overclot, promotes fibrolysis, enhances granulocyte site function, helps those white cells perform a little bit better, and it's a potent anti-inflammatory agent. So everything about insulin is good, and that's why we use it. We'll mostly use it because it works, but we use it also because of those other dazzling properties. And one question that always comes up is it less serious if a patient has never had diabetes before? They come in the hospital, the sugar's running 150, 160, 200. They tell you they've never been hyperglycemic before. Does that make it less serious? And the answer is no. This is data probably going back almost 20 years now, where they looked at patients on admission, looking at who was their total mortality, comparing those with normal glycemia. Total mortality was 1.7%. Those with known diabetes had a doubling of the mortality rate, 3.8%. But look at the new onset hyperglycemia patients. They had a horrific mortality, 16%, probably because nobody was paying attention to their sugars if they didn't have a history of diabetes. Again, it's got a higher mortality, so don't ignore it. They've also shown that new onset hyperglycemia patients are 3 times as likely to be admitted to the ICU. They have about twice the length of stay. So don't ignore new onset hyperglycemia. It is just as serious as known diabetes. Be aggressive, treat it, do something about it, okay? So our goal is 140 to 180 in the hospital. Let's talk about how to get there, how you're gonna achieve that goal. Well, we're gonna lean on insulin as we talked about. In the ICU setting, we love IV insulin. IV insulin drips are great. There's 3 or 4 insulin protocols out there for IV insulin. At Loyola, we use EndoTools, and I'm just going to spend a moment on EndoTools because I'm not sure if you're all familiar with how EndoTools works. It's really a nurse-driven protocol, and again, we've done really well. At the end, I'll talk about sub-Q EndoTools, which is coming. I'll just sort of whet your appetite that we're going to be going to sub-Q EndoTools pretty soon. That'll put you guys out of business. You won't have to think at all. The computer will do it for you. But anyway, let's look at EndoTools IV, which is what we're currently using. EndoTools IV is an FDA-approved protocol. It's a medical device that uses a complex multifactorial algorithm to predict the patient's blood sugar and their response to insulin. Okay, so it's really patient dependent. The patient-specific factors that are entered into the algorithm when the patient hits the door in the ICU and the sugar's high, you put in the type of diabetic they are, type 1, type 2, new onset, gestational, unknown, etc. The age of the patient, their height and weight, whether they're on steroids or not, and what the dose is, put in the estimated GFR, if they're eating or if they're getting IV carbohydrates, and has insulin been ordered or not. Finally, what's also entered into EndoTools is the historic response to insulin dosing. Have they been insulin resistant or insulin sensitive? So again, all this data goes into EndoTools. It's entered by the nurse. And the reason we like it so much is because prior to EndoTools here on the bottom, it was we used all these paper protocols. Loyola, believe me, we've tried them all. And we've had pretty much bad experience with all the paper protocols we were using. If you look at blood sugar, patient comes into the hospital with a blood sugar of 300 across the board. Well, this patient is a 22-year-old, no history of diabetes, and a great creatinine. This patient's 45, very thin, 38 kilos, of type 1 diabetic, creatinine of 2.2. This patient's 33 years old, overweight, 109 kilos, type 2 diabetes, creatinine of 1.9. And this patient is elderly, 62 years old, very heavy, 109 kilos, type 2, serum creatinine of 1.1. All these patients come in with a sugar of 300. Most of the protocols we were using before was kind of a one-size-fits-all. Based on their blood sugar, they were all put on an insulin drip rate around 5 units, okay, depending on which protocol you were following. EndoTool says, no, it can't be one-size-fits-all. That's not right. There's too many other things in the mix that you've got to think about, and that's all those factors that we just discussed. So with EndoTools, this person here, this 22-year-old with no history of diabetes and good-looking kidneys, is going to start with a drip rate of 6.5 units an hour. This person over here is a type 1 diabetic, 38 kilos, not so good looking kidney function. That patient's going to start at a much lower drip rate, 3.4. This guy over here, very insulin resistant, type 2 diabetic, serum creatinine of 1.9, going to start at 13 units an hour. And this overweight person over here with better looking kidneys, they're going to start with a drip rate of 18 units an hour. So endo tools will tell you how to start that drip rate, okay, when the patient first hits the door based on all those other factors. So it's a nonlinear dosing curve that gets us to goal. Here's the target range, 140 to 180. It gets you there in about 4 to 5 hours. We're not in a big hurry to get there. We want to make sure it's going down. The paper protocols, again, we were all over the lot. It took forever to get there, and we didn't get there safely. With endo chills, we get our patients to go pretty much within 4.5 hours, and then they stay there. Again, it's a nurse-driven protocol. So when the patient comes in, it's linked to all the data we just talked about. The nurse enters all that data into the computer, and then the nurse has to enter in whether they're using the garden variety hyperglycemic protocol or if they're in DKA or HHS, okay? So somebody's got to let their nurse know which kind of protocol to use. There's 3 choices. Garden variety hyperglycemia, that's probably 95% of them. DKA and HHS are the other choices the nurse can choose. What's the difference? Well, the difference is the trigger, okay? The goal is a little bit different too. For DKA, sugar goal is about 250 for switching over. With HHS, it's 250, but there's a little bit more wiggle room over here for switching the patient from the DKA protocol, HHS protocol, to the hyperglycemic protocol. Once they get to that sugar of about 250, the nurse will get a pop-up saying, okay, they've got, their gap is closed now. Your sugar's where you want it. Do you want to switch over to the hyperglycemic protocol for either DKA or HHS? Well, they've got to hit yes, confirm it. And now the patient is shifted into the usual hyperglycemic protocol, again, getting them down to that 140 to 180 goal. The typical workflow is to put the blood sugar in every hour, to mark it, to put in whether the patient's eating or getting extra calories, if they're getting IV glucose, etc. Confirm the dose that they're supposed to get, and then stop endo tools when it's appropriate. An atypical workflow would be dose deviations, like huge spreads in the dose. The insulin dose is really changing, wild swings, and that would be a clue that something funny is going on. Supplemental carbs that sometimes aren't documented, whether they got treated for hypoglycemia and was it noted, or was the blood sugar deleted by mistake. Those will give you wide swings again in the insulin dosing. The nurses have to know this too. The blood sample has to be entered within 5 minutes, but no later than 20 minutes. It's got to be a real-time blood sugar. So again, this is a problem. Sometimes blood sugars are entered too late. It's done, but it's not entered immediately. The sample has to be consistent. Could be a finger stick, could be a venous or an arterial sample, but you can't go back and forth. You have to stick with one sample methodology. Usually it's a finger stick. Remember, you can't use finger sticks, however, if they're vasoconstricted. So in the ICU, that's a problem. If they're on pressors, you can't rely on those finger sticks. If they're not perfusing well for any reason, Raynaud's disease or whatever, you can't use finger sticks. You've got to go with arterial sampling or venous sampling and then stick with that methodology. And the sample should be analyzed by the same POC point of care device. That's usually the case, but sometimes in the OR, they use a different one. And so that can be a little bit problematic too, if you're moving from one device to the other. This is what the screen looks like on EndoTool. So a patient comes into the ICU, and the patient's data is entered by the nurse, okay? The kind of diabetes, well, obviously this is a guy and he's got gestational, so it's got to be clicked down to a different kind of diabetes, but the creatinine's got to get entered, what the blood sugar is, their height, their weight, their current A1C or their most recent A1C will be marketed in, then their blood sugar is put in, and the EndoTools algorithm will take it from there. They'll take all that data, put it together, and tell the nurse how much insulin to start, 3 units an hour, say. 1 hour later, the blood sugar is checked again, and the dose can be adjusted unless something intervenes. And again, it always has to be confirmed. So it's pretty cookbook from that point on. Extra carbs need to be entered. Sometimes patients are given a popsicle or Italian ice or something, and that'll raise their sugar. And you don't want to turn up the drip rate for that. Okay, you want to keep the drip rate going. It just has to be entered. If they got to give you dextrose for an antibiotic, whatever. If they eat, how much did they eat? The nurses know how to count carbs, so they should cover the carbs that were consumed. And then they've got to remember to put the meal timer on so that the blood sugar could be rechecked once they finish the meal. The nurses get 2 choices, the oral carbohydrates or the IV dextrose. So it's only one or the other. It can't be both, okay? That data is entered over here on their screen. They just push the button and then they have to put in how many carbs the patient consumed, how much carbohydrate was given. If the patient does get hypoglycemic, they've got to have a preset trigger, like we don't want the blood sugar ever to be under 120 or under 140, whatever you decide. And then the EndoTools will again tell the nurse to recheck the blood sugar 15 minutes after that hypoglycemic episode was treated, turn the drip off or ratchet it way down, and then recheck it in 15 minutes to make sure that it's back where it should be. Also with endo tools, one thing we love about it is they can enter whether they're on TPN or not, and if the TPN is being held for a test or a procedure. That's hugely important. Okay, they have to know to, again, either put the insulin on suspend or turn it way down. So endo tools has to know if the TPN or the tube feeds rather, or TPN are put on hold for any reason. That's something, again, the nurse has to remember to put in. And then finally, steroids are hugely important, as we'll talk about later. The nurse has to enter whether they got steroids and how much, how it was given, and is it going to be a continual drip, or is it going to be given a 40 milligram prednisone dose, or what? So again, the amount of steroids, how the patient got the steroids, and the amount of steroids all has to be entered. So I don't think you guys are even aware of it because it's kind of going on behind the scenes, but it's a lot of work for the nurses, and sometimes we get a little bit of pushback. Most of the nurses are great, and they allow us to use this because it works so well. But it is a little bit of work for them because they've got to be on top of it, constantly adjusting. That's why it's usually in a place where there's one-on-one nursing or two-on-one nursing. The nurse has time for all this. Once the patient's drip rate is stable and the drip rate isn't changing much, they have to confirm that they're stable, and then they say, do you want to transition from IV to sub-Q insulin? Again, we love IV insulin, but at some point they've got to come off of it. So the pop-up will come from endo tools saying, hey, this person's on a stable drip right now for 4 hours or 6 hours, whatever that parameter is set at. What do you think? Can we go ahead and get them off endo tools, transition to the sub-Q? And if you say, yeah, it's fine to go ahead and transition, you would confirm it. And then endo tools will give you what they think is the best way to transition them into the basal bolus regimen that they think is most appropriate based for this patient. When is it not safe to transition? Well, if the patient's hemodynamically unstable, maybe the drip rate is stable, but nothing else is. So if they're unstable, you say, no, don't transition yet. Sometimes on the consult service, we'll get a little bit of pushback because they want to take a patient off the drip and get them out of the ICU. But it's really not a good idea if that patient's not hemodynamically stable. If they're on a really high infusion rate, you should probably wait till it's down to about 3 units an hour or a little bit less. We had a patient recently on 25 units an hour. That was not a good time to transition that patient to sub-Q. It never would have worked. So you want that drip rate stable and then not too high of a rate. Variable insulin, again, you shouldn't be changing them, getting them off the drip yet. High doses of steroids that are being adjusted, that's not a good time. Also, with other things to consider, if the patient got septic, if their tube feeds are being radically changed, etc., all that needs to be considered in the mix of when they're stable. And they should not be in DKHHS mode. They should have been transitioned into the hyperglycemic mode in order to be transitioned to sub-Q insulin at that point. So the transition has a lot into it. At Loyola, we kind of go with 80%. And we set this goals based on the literature. Whatever that drip rate was going at, they're going to probably need a little bit less now because they're less sick. Okay, they're getting healthier. So in general, we go with 80% of what the drip rate was going at when they're stable, when that drip rate is stable. In general, if they're eating, we like 55. We set the parameters for 55% of the total daily dose to be given as basal. And then the other 45% is given as bolus, 15% for breakfast, 15% for lunch, 15% for dinner is the kind we worked it out if they're eating, okay? So again, this is Loyola's parameters. This may change at other hospitals that you go to. We had this set at a different rate before and it wasn't working as well, but we're seeing how this one goes. For patients on continuous nutrition, they usually stay at 100% of the drip rate as the sub-Q dose because there's no bolus. They're not really eating. It's a continuous tube feed. And then once the nurse gives the basal insulin, once they get the Lantus going, you have to wait 2 hours because IV insulin wears off in minutes. And the sub-Q insulin Lantus takes 2 hours to get to its level. So you really want to give it that 2 hour time frame for the basal insulin to kick in and get going before you shut off the IV insulin. And then again, we're going to calculate it at about 80%. Again, these are parameters that may change. You have to let us know if you don't think Endo Tools is working so we can relook at it and see if it does need to be adjusted. Also, you have to take into consideration is the patient's nutritional status going to change when they're coming off endo tools. Sometimes they're healthier and now they're eating full meals and sometimes they're not. Sometimes the D5 drip is being stopped at that time, etc. So you have to kind of take all that into consideration when you're taking them off endo tools. Now, we are going to be going to EndoTool sub-Q once the administration approves it. It's a little bit pricey, but that means every computer is going to have the sub-Q protocol. All these things are going to be taken in. All that data that we talked about will be entered in, and then it'll decide how much basal and how much bolus the patient should be getting. So once this is approved by administration, we'll move forward with that. So it'll make your life easier. You won't have to be figuring out insulin doses, but we don't have it yet. We don't have sub-Q EndoTools yet. We only have IV EndoTools going. And I just want to mention that with IV EndoTools, our incidence of hypoglycemia is less than 0.3%. It's really, really low, which is great. With sub-Q EndoTools, the incidence of hypoglycemia is about 0.5%, really low. So I know we can do better with sub-Q EndoTools. We just have to get it in place. So for right now, until we get sub-Q EndoTools, you've got to be the EndoTools people. You have to decide how much insulin they need, how much sub-Q insulin. The transition from IV to sub-Q is done usually at Loyola based on basal bolus physiology or basal bolus thinking. Remember, 50% of what your body puts out is basal insulin. The other 50% is bolus insulin. I don't know why people forget this. The bolus has two components. It's got the parenteral component to cover the food that the patient's going to be eating, and it's got the correction component. That's our algorithms, A, B, and C, okay? So the bolus has two components, the food component, the parenteral component, and the correction component. This is given as one dose of insulin when the patient's eating. First, for the basal component, one thing we do if you're not using EndoTools, or if you don't think EndoTools is accurate, you can multiply the last drip rate when they were stable by 20. That's about 80% of what the drip was going at, and that will help you know the transition to Atlantis dosage. Okay, you could go that way. So just multiply the last drip rate by 20. That should give it to you. Give the Atlantis, wait 2 hours, and turn the IV drip off. Or you can use body weight base, and this is what we use all the time in patients that are not in the ICU, patients that are hitting the floor, coming in on oral agents. We stop the oral agents, we get them on sub-Q insulin, and we do that based on their body weight in general, okay? So you can use for known type 1, 0.4 units per kilo. This is total. Or you can go with 0.6. This is for most of the patients with type 2s. 90% of our hospital patients fit in here. And then we give 50% of that total dose you calculated, 50% to the Lantus, the glargine. The other 50% is the bolus component. Remember the bolus, again, two components. So when they're going to start to eat, you want to give them that rapid acting. We use Lispro here at Loyola. Heinz uses Aspart or Novolog, but you want to use that rapid acting component to cover the food. And again, it's that 50-50 rule, so pretty easy, a third for each meal. So it looks like this, if somebody's going to need 60 units of insulin total, cut it in half. 30 units would be the glargine dose over here. It's 10, 10, 10, that equals 30 of the rapid acting dose. And here at Loyola, the blood sugar is checked AC before every meal, and then they're given the insulin after the meal. It's dosed after the meal to make sure they really ate the meal. And also the nurse will check the blood sugar before the meal and decide if they need to add a little correction or not. That's the boxes that we use. We call them algorithm A, B, and C, or low dose, medium dose, and high dose. Low dose is less than 40 units a day total insulin. Algo B is medium dose algorithm. That's insulin dose of 40 to 80 units. Algo C is if they're on more than 80 units a day. And we do have an Algo D if they're really, really insulin resistant and their insulin dose is more than 120 units a day, they go into Algo D. But as you can see the difference here, here for a sugar of around 200, the nurse would be adding 1 unit to the parenteral dose they were going to get. If they were going to get 10 to cover the carbs or cover the food, and the sugar's 200, they would add 1. They'd get 11 for that meal. But if they're over here in if they're in Algo B over here, they'd get 2 units, and if they're in Algo C, they'd get 3 units. So in an attempt to get at insulin sensitivity, okay, everybody's a little bit different in their insulin sensitivity. This is for a patient who's very insulin sensitive, medium insulin sensitivity, and insulin resistant. Most patients fall here. This is Algo B. Most of our patients are here in the medium sensitivity group, okay? So it's about if you look over here, it looks like there's a 50-point spread between these blood sugars. And again, you're going up by 2 units. Looks like a 1 to 25 correction. So here you've got a 1 to 50, 1 to 40, 50 correction. Here it's a 1 to 25 correction. Here it's a correction that's much stronger, more like a 1 to 15, 1 to 20 correction. So on the outpatient side, we never use Algo A, B, and C. It's unheard of. On the outpatient side, we give them their sensitivity factor based on their total insulin requirement. We tell them what their correction should be, but in the hospital, there's no time to do that. So in the hospital, it's algo A, B, and C, the way that we correct for a high blood sugar. So remember, the bolus has two components, the parenteral component to cover the food, and the bolus, the correction component to knock down that high sugar. And again, it's dosed after the meal. So those are patients transitioning from IV to sub-Q insulin. What about patients that come into the floor? This is most patients. Most patients aren't coming out of the unit. They're just being admitted to the hospital from the ED or whatever. So we start from scratch. You want to calculate their total daily dose of insulin. Now, if they're on insulin, it's easy. Add up the insulin they're getting as an outpatient. That's their total daily dose of insulin. If it's premix 70-30, if it's basal bolus, whatever they're on, add it all up. That's their total dose of insulin. Or you can use their body weight. And we use this all the time, 0.6 units per kilo, half basal, half bolus. Okay, so come up with the number, come up with the total daily dose of insulin for that person. This is a little bit conservative, but it's a good way to get started. So whatever number you take, cut that number in half. Okay, so if they're 100 kilos and you're doing 0.6 units per kilo, that's 60 units of insulin. Cut it in half. 30 would be the glargine, 10, 10, 10 would be the mealtime. Right? So do it that way. And again, that's going to give you the parenteral dose. Then you want to put them in the right correction, the right algorithm, whether it be algo A, B, or C. So if they're 100 kilos times 0.6, 60 units, 30 glargine, 10, 10, 10 mealtime, that's going to get them into algo B, okay? Because they're in between that 40 to 80 group. So that would be algo B. And this dose is always given after the meal. On the outpatient side, patients take their mealtime dose before they eat. On the inpatient side, it's after, because patients often don't like the meal. They push it away. The family member eats the tray. They just don't have an appetite or whatever. They don't like our food. So the nurse comes in after the meal, after they supposedly ate the meal, and looks at it and says, did you eat the whole tray? Did you eat half the tray, a third of the tray? If they ate half the meal, they don't get the full dose here. They only get half of it. If they didn't eat any of it, the nurse doesn't give any. They just give the correction dose, but they don't give any parenteral. So again, it puts the burden on the nurse to decide how much of the parenteral dose they're going to get, how much of this bolus dose they're going to get, depending on what they ate. And that's why it's given after they eat, to make sure they really got that food going, okay? How about oral agents? Well, as we kind of hinted at, we don't use them in the hospital, okay? Secretagogues are the sulfonylureas and the DPP-4 inhibitors. So sulfonylureas are not a good choice probably ever, but they're not a good choice in the hospital because they can lead to too much hypoglycemia. They drive that beta cell to put out insulin. And if you're NPO for a test or a procedure, you're going to become hypoglycemic. In the hospital, the patient can't run to the refrigerator and get juice. They're kind of stuck ringing the bell for the nurse to come because they don't feel good. They know their sugar's dropping. So we don't like sulfonylureas in the hospital, but we do like DPP-4 inhibitors. The DPP-4 inhibitors are sitagliptin and linagliptin. That's Januvia and Tradjenta. They are allowed in the hospital. They're very gentle. DPP-4 inhibitors are smart medications. They're in that incretin-based category of medication. That means that they know, we call them smart pills, because they know when your sugar's dropping not to put out more insulin. Unlike a sulfonylurea, which will keep driving the beta cell, the DPP-4 inhibitors, when the sugar's dropping, will stop stimulating the beta cell. So we do allow sitagliptin, that's Januvia, and linagliptin, that's Tradjenta, in the hospital. They're also safe because you can use them in people on dialysis. Okay, if you have to renally dose them, you've got to cut the dose back a little bit for sitagliptin, but they're safe even with kidney disease. And then the GFR is fluctuating quite a bit like it does in the hospital. That's a big deal. So we do allow DPP-4 inhibitors, but we don't allow sulfonylureas, which is too dangerous in the hospital. Alpha glucosidase inhibitors, we don't use those very much. Those are drugs like Glycet and Precoce. They are drugs that kind of stimulate the beta cell to put out insulin on demand, but again, they can lead to hypoglycemia, so we don't use them either. Metformin, we choose not to use it in the hospital until you're healthy and going home. Metformin is a great drug for the healthy. It's a terrible drug if you're sick, okay? You don't want to have that association with lactic acidosis. And metformin has to be put on hold for acute illness. That's most of the hospital patients. For renal, cardiac, or liver function instability, that's a lot of the people in the hospital. If you're going to surgery, having any procedures, or if you're going to have IV contrast dye, it's on hold. Well, this is a lot of the patients we see in the hospital. So metformin is usually on hold until they're going home. At the time of discharge, If you want to put them on it, the creatinine's doing okay, not a problem. But again, we hold it when they get to the door, when they first come in. Glitazones are the drugs like pioglitazone and rosiglitazone, Actos and Avandia. If they're on it, you can probably use it in the hospital because they're safe in kidney failure. They also do not cause hypoglycemia, but they're not a good drug in the hospital because they can lead to edema. And then some people have trouble with congestive heart failure. So not a good choice in the hospital. Plus they take a while to kick in. So if you start one today, it's going to start working in a week or 10 days. That won't help you in the hospital. And then finally, how about those SGLT2 inhibitors? They're not indicated for acute illness. And again, with the renal function kind of bouncing around and being variable, an SGLT2 inhibitor is probably not a good choice in the hospital setting. So if they're on Invokana or Farxiga or Jardiance, you should probably hold it until the time of discharge. When they're getting ready to go home, then it's okay to give them back that medication. We love them on the outpatient side. We use them like crazy, but on the inpatient side, it's only insulin. Like I said, insulin's the only game in town. Now, how about when they're getting ready to go home? Well, on admission, when they come into the hospital, you want to have a discharge plan in place. When they first come in to the hospital on admission, you should always get that A1C, unless they had one in the last 2 to 3 months. If they've had one in the last 2 to 3 months, you don't need to get it. If they're severely anemic, don't get it. Because remember, A1C is the amount of sugar attached to normal red blood cells. If they've been transfused, don't get it. They've got somebody else's blood going, so the A1C won't be accurate. If they've got an abnormal hemoglobin variant like sickle cell or G6PD deficiency, thalassemia, don't get it. It won't be accurate. But otherwise, if they haven't had one lately, get an A1C on admission and put it in your back pocket. It's not going to help you one iota during the hospitalization. You're going to treat them with insulin, body weight basis, 0.6 units per kilo, half basal, half bolus, etc. You're going to do that regardless. But at the time of discharge, look at that A1C and say, your A1C on admission was 6.7, you were doing pretty good. Go back on your metformin, your Januvia, whatever you were taking. Or you know what, that A1C was 9 when you walked in the door. That metformin and Januvia wasn't strong enough for you. Let's keep the basal insulin going. Let's add something else. Let's get other medication going, because what we were doing on the outpatient side wasn't working that well. So oftentimes the decision is made to send them home with the basal insulin on board and let them resume their oral agents if the A1C was high when they first hit the door. A1C on admission can be very, very helpful. If it's acceptable, put them back on the pre-admission regimen, but if it was high, and keep that basal insulin going, send them home with some basal insulin. Now, if you're thinking, okay, what's going on with this patient, you have to look at the natural history of diabetes. What kind of medication should I send them home with? This is the natural history of type 2 diabetes, and it hasn't changed in forever. This is the pre-diabetic phase over here. You're diagnosed with diabetes at year 0. And what's been going on here is your fasting sugar in blue crosses the red line, crosses the dotted line of 126. Now your fasting is higher than 126. So you're an official diabetic, but it's been brewing for years. Okay, the beta cell over here has been working very hard to put out enough insulin to keep your fasting sugar under control, to keep your 2-hour postprandial under control. Now at year 0, you've lost about 70% of your beta cell function. That beta cell's been working so hard to overcome insulin resistance for 5 to 10 years that you can't drive it much harder. You've lost 70%, you lose the remaining 30% over the next 10 to 12 years. And that's why our patients that have been type 2 diabetic for 12 to 15 years are usually looking at least basal insulin, and oftentimes mealtime. Type 2 evolves into type 1 over time, okay? So if they ask them how long they've been diabetic, and if they've been diabetic, under 10 years, they probably have some beta cell reserve going. So maybe you can still drive this. You can break insulin resistance with the metformin. You can help them out with maybe a GLP-1 agonist, a weekly drug, like one of the ones we use now are Ozempic and Trulicity. Those are great drugs. You can drive the beta cell if they have beta cell reserve. But if they're down here on the curve, if they've been diabetic for 12 to 15 years, they certainly need basal insulin. And when they've been diabetic longer, they're probably going to need bolus insulin too. So again, asking them how long they've been diabetic might help guide you into the outpatient regimen that you're going to be sending them home with. Okay, that depends on how much beta cell reserve they have left. And then make sure that they're educated. And we don't have a diabetes in-house educator. They're so busy on the outpatient side that they don't come to the hospital. But again, every nurse in the hospital knows diabetes survival skills. That means any nurse in the hospital can teach a patient how to check their blood sugar, what the goal should be, what hypoglycemia is like, how to give insulin, okay? about the mealtime, the basal bolus. So make sure you get diabetes survival skills in place for someone who's going home, especially if they're newly diagnosed with diabetes, and especially if they're going home on insulin. Let's just kind of wind up with a little bit on the special situations that we deal with in the hospital. We've been talking about the usual patients that come in the hospital, the ICU patients, endo tools, transition them to sub-Q insulin, easy breezy. Patients that come in the hospital on oral agents or on insulin, figure out how much they need, get them off the oral agents because you can't use them in the hospital. Body weight basic, 0.6 units per kilo for a type 2, half basal, half bolus. But those are the patients that are the usual ones. They're the ones that have normal kidneys, they're not on steroids, they're not on tube feeding. What about these other situations? We call them special situations that you have to know what to deal with. So one special situation is, again, patient whose renal function is deteriorating in the hospital. Unfortunately, we see this way too often because of the nephrotoxic drugs we give them, because they're dehydrated, because they get IV contrast. So for a variety of reasons, worsening renal function, or AKI, superimposed on CKD, is a very common diagnosis. And what do you do for these people? Well, you have to recognize that they're very high risk of becoming hypoglycemia. What's the impact of renal failure on hyperglycemia? It decreases insulin clearance. Insulin is cleared by the kidney. When the kidney function is going down, the insulin's hanging around longer, predisposing that patient to hypoglycemia. And a third of your body's blood sugar is made by the kidney. 2/3 made by the liver, hepatic gluconeogenesis. A third is made by the kidney. If you knock out the kidney, now they no longer have renal gluconeogenesis, and now you're giving them insulin and it's hanging around longer. You're setting them up for hypoglycemia. Okay, so you want to be aware of that. So the protocols we have in place tell us that if the GFR is greater than 30, body weight basic, no need to change that. Okay, that's the number you calculated for the total daily dose of insulin based on their body weight, no change. But if the GFR is 15 to 29, you need to reduce it, okay? Because again, the insulin's hanging around longer, and you've knocked out renal gluconeogenesis, reduce it to 70% of what you calculated. If you calculated 60 units of insulin, reduce that, okay? Go down by to 70%, because it's gonna make them hypoglycemic if you go for the full amount. If the GFR is less than 15, or they're on dialysis, cut it in half, okay? So if you calculated 60 units based on their body weight, or 100 kilos times 0.6, that's 60 units, but they've got a GFR of 12, cut that 60 in half, make it 30. And then of that 30, 15 would be Lantus, 555 would be the Humalog dose, the Lispro dose, okay? So it's gonna change their insulin dose dramatically when they've got CKD. And in the hospital, if the renal function is getting worse, make sure you start backing off a little bit on that insulin so that they don't become hypoglycemic on you. Other considerations of the dialysis, if they're on dialysis, can improve insulin sensitivity, and recognize that serum creatinine is not very good. You want the GFR, because serum creatinine is dependent on muscle mass, right? And if you're kind of a wasted weight little old person, your muscle mass isn't that good anyway. So the GFR is not going to look that bad when it's probably worse than that. So look at the GFR in the hospital setting, okay? And remember, if they go for dialysis, that's going to improve insulin sensitivity. Another special situation are patients that are getting corticosteroids. Corticosteroids are good and bad. We love them for all the good they do for inflammation, et cetera. But we know that the majority of patients that get glucocorticoids are going to become hyperglycemic, and often markedly hyperglycemic. Okay, so anybody in the hospital, when they're going on high dose glucocorticoids, needs to have their sugar checked, even if they're not a known diabetic, even if their sugar when they walk in the door is okay. Watch them. When you give them high dose steroids, you can almost bet you're going to unmask hyperglycemia. Without diabetes, it's recommended to check them, make sure that sugar remains under 140 without any insulin for about a day or two. But if they're a known diabetic, you want to be very careful, and you want to monitor it and start making insulin adjustments, okay? And then use continuous insulin infusions if they're really severe elevation when they're getting high dose steroids, because basal bolus will be a little bit hard to catch up. Okay, so again, start monitoring those patients when they come in and they're getting high dose steroids. And then you want to be prepared. If they're on insulin, you want to go up on the outpatient side. We tell our patients when they get steroid injections in the knee or the shoulder to go up around 20% to start with, but often that's not enough, and you have to go up to 40% to keep that sugar under control. So we know they become very insulin resistant You can start with an increase of about 20% in what your calculated dose of insulin is, but be prepared that that won't be enough, that you're probably going to go more towards the 40% increase in insulin dosing. And then you should change the algo too. If they're on algo A, it's going to be too gentle, go to B. If they're on algo B, go to algo C, okay? And then again, checking those sugars and being aggressive with your dosing of insulin is really important. What do glucocorticoids do? They increase insulin resistance, and you're always worse in the postprandial phase. You don't want to be tweaking the Lantus because that's going to make them low overnight. It's daytime hyperglycemia you're going to deal with if they're getting prednisone, okay, or hydrocortisone in the morning. Okay, so because if this is the 50-50 rule we talked about, 50% bolus, 50% basal, because steroids are going to raise your sugar during the day, but not overnight, we recommend going higher on the prandial dosing. When you take your prednisone here first thing in the morning, you know it's going to start going up in about 2 hours. You're going to be high from 10 in the morning all the way through dinner time, and then it's going to start going down. So high dose steroids in the morning are going to make you high in the day, but not overnight. So you want to tweak it, you want to change it, you want to give more prandial and not adjust the basal. Now, if you want, you can ask the team who's writing the steroids to change the prednisone dosing, like rather than giving 40 milligrams in the morning, making them high all day, can you split the dose? Can you go 20 every 12 hours to help spread out that hyperglycemia? That's one option. If they let you, that's fine, but a lot of times it's not a good option. They really want that one dose in the morning. But if you did this, it would help. The only trouble with the 20 milligrams late in the day or in the evening is it's going to cause insomnia. So that's the only problem with taking your steroids late in the day. That's why oftentimes the rheumatologists I know are very big on morning dosing of prednisone, that being one of the reasons. So if you can split it, that's great. It would spread out the hyperglycemia. Then you could continue to change your Lantus and your prandial dose at the same time. Otherwise, if they know they want prednisone in the morning, be prepared for hyperglycemia all day, but not overnight. They'll get low overnight if you raise the Lantus dose. So that's one option. Another option is to change the prednisone or the hydrocortisone to a longer steroid like dexamethasone. That's usually not something that they want to do either, okay? Or if you want, you can keep them on what they were doing, but with glucocorticoids, you can add a little NPH. It seems like God made NPH for steroids. You get prednisone in the morning, man, you're high all day, but not overnight. So NPH, sometimes if we just add in 10 units of NPH in the morning, we'll cover it, and you don't have to make adjustments to the basal bolus. But otherwise, if they're on prednisone in the morning, adjust the mealtime dosing, but don't adjust the Lantus dosing. You'll get them low overnight, all right? But think about NPH in the morning. It may be an option for you. Another special situation that we deal with in the hospital are the tube feeding patients, because tube feedings have a lot of carbohydrate. You know that. Also, the patients that are on tube feedings are pretty sick patients. Okay, so in general, they're getting a lot of carbohydrates. Even a stable diabetic becomes unstable when they go into a tube feeding regimen, and they also have this higher severity of illness, which can go against them, making them become more insulin resistant. Something we battle all the time is stopping the tube feedings, or the rate gets changed, and this leads to hypoglycemia. At Loyola, when we tracked the most common causes of hypoglycemia hospital-wide, we followed like 800 people over the course of a few years. Far and away, thumbs down, the most common cause was this temporary stopping of the tube feeding. The patient goes for a test or procedure, the tube feed is discontinued or clamped, and yet they have all that Lantus going and all that insulin going. So when they go for a test or procedure and you're going to shut off the tube feeding, you immediately have to have dextrose going. So everybody's got to have a HEP block in just for that purpose alone. So they have to get some dextrose containing food going. Usually D5 is enough at the same rate as a tube feed. If it was 55 cc's an hour in the tube feed, then make it 55 cc's an hour on the dextrose, okay? But get some dextrose going, otherwise they're going to crash on you because they've got all that insulin going. So there's 5 different kinds of tube feeding here at Loyola. We have continuous tube feeding. That's like the entry level when patients are just starting to get a little, coming out of a really horrific ICU experience and they're really malnourished and wasted. They're usually on continuous tube feedings, but over time they graduate. They graduate to nocturnal tube feedings and they eat during the day, or they go to bolus feedings, which are sometimes called gravity feedings, or just cycle tube feedings. And in the burn unit, they use volume-based tube feedings. So continuous tube feedings is just a constant inflow of carbohydrate. The cycle tube feeds are usually where they're getting some every 6 hours predictably, but it's cycled in over about 3 to 4 hours. Bolus tube feeds are just that. It's pushed in over about 20 minutes. So it's kind of like a liquid meal. They call it gravity, but it's not really gravity. The nurse usually just pushes it in. It doesn't really drip in. Those are called bolus tube feedings. Nocturnal tube feeds are variable. Sometimes they go from like 8 p.m. until 6 a.m. Sometimes they go 6 p.m. to 6 a.m. Sometimes they go midnight to 6 a.m. So it depends on what kind of nocturnal tube feeding you're getting, what that rate's going to be, how much carbohydrate is in there to help you know how to dose the insulin for that. Volume-based is really tough for us. Volume-based, like I said, they use it in the burn unit. Patients in the burn unit get about 7,000 calories a day. They're so catabolic. And when they go for these debridement procedures, which is about every day or every other day, they're in the debridement OR, the debridement room for about 3 to 4 hours. So their tube feeds are stopped. Well, then when they come back from that debridement procedure, they've got to make up the tube feeds that they missed. So we got to get that 7,000 calories in one way or another. So the tube feed changes from 0, and they had some glucose going, and now it's the tube feed rate has been doubled up or tripled up to try to catch up. That's called volume-based. Very, very difficult for us to know how to manage the insulin for that one. But the other ones are not that bad. For continuous tube feeding, I'll show you what we usually do for continuous. Because there's a persistent carbohydrate load coming, there's persistent hyperglycemia. So in general, you could just give them all Lantus insulin. There's no basal bolus because they're not really eating it all. There's no meals here. So you could just give Lantus, and you could just give them a little higher dose because there is more carbs than what they're usually eating. So instead of a 0.6 units per kilo, we go with 0.8 units per kilo. They get a higher dose. If they're a type 1, instead of 0.4 units per kilo, they get 0.6 units per kilo. So again, a 100 kilo person would get 80 units of Lantus to cover that continuous tube feed. However, that's probably not the best strategy because when you have 80 units of Lantus going, there's that huge potential for hypoglycemia when the tube feed is disconnected or discontinued for whatever reason, like gastric residuals is another reason tube feeds are stopped. Anyway, because you've got so much Lantus on board, it gets into trouble with hypoglycemia. So we actually prefer this. We actually prefer that you give some basal and some rapid acting. And the formula that seems to work the best here at Loyola is to give about 40% as basal and the remaining 60% as Lispro, rapid acting insulin, every 6 hours. So it kind of looks like this, okay? There's the basal going, about 40% of it's going to be basal. Here's your persistent hyperglycemia. There's the insulin. 40% of it's going to be basal insulin going, the Lantus, and then the remaining 60% will be Lispro given every 6 hours. I didn't make this up very well, so that's spaced out very well. But again, if they're a 100 kilogram person, okay, you're going to give them 0.8 units per kilo, 80 units. That would be 32 units of the Lantus, and then the remaining 60% would be 68 units of Lispro. So 68 divided by 4 would be 17 units, 17 units, 17 units, 17 units, okay? And then the nurse would check the blood sugar before they give that 17 units. And using Algo C, because now they're in high dose, they'd be in Algo C, they use a little corrections if needed. So this works pretty well for controlling our patients with continuous tube feedings, okay? Rapid acting every 6 hours, and 40% of it being given as Lantus basal insulin on the background. And how do you adjust it? Well, if the blood sugar is starting to drift down towards 120, then we go 10%, cut back 10%. And if it's going down more than that, go down even low. We could go down even more, 20%. Otherwise, if you're not getting enough control, if their sugars are running high, add up all the correction they needed and then roll it into the next day's dose. So if they needed 10 units of correction, then you could give like 2 units with each of those doses of the rapid acting and an extra 2 units with their Lantus dose. So just add up all the correction they got, roll it into their Lantus and their Lispro dose. And then if they are starting to eat a little bit while they're on that tube feed, we recommend carb counting. Give them 1 unit of rapid acting for every 15 grams of carbohydrate. And the nurses are really good at this. If you put down a 1 to 15 carb ratio, they'll know exactly how much to dose the patient with. Remember hypoglycemia, I really want to hit home on this because it's been such a problem. Immediately get D5 going if the tube feed is stopped for any reason at all, so they don't get hypoglycemic. Then again, you've got the cyclic tube feeds and bolus tube feeds. And we use rapid acting for the bolus tube feeds. It's like a liquid meal. We just use Lispro for that. Okay, we give them 10 or 15 units, depending on how many carbs they're getting for the bolus tube feeds. For the cycle tube feeds, Sometimes we use regular insulin, or we give rapid acting and regular insulin together to try to cover it, because these cycle tube feeds are usually dripped in over about 4 hours. So again, you want to give them a little bit more insulin coverage. It's a little bit thorny, and that's where we usually get involved in the pre-consults, usually sees these patients. If they're getting a bedtime tube feed, we use NPH. NPH is great for a bedtime feed. Okay, it'll cover the 6 or 8 hours of the tube feed perfectly. So if it's a 6 or 8 hour, like if it's midnight to 6 a.m. or 10 p.m. to 6 a.m., we just give 10 or 15 or 20 units of NPH to cover it, depending on how many carbs they're getting. If it's a 12-hour tube feed, if it's going to be 6 p.m. to 6 a.m., NPH won't last that long. It only lasts about 6 to 7 hours. Then we split it. We give half at the start of the tube feed, and we give the other half at midnight for the remainder of the tube feed that's going to be going. So we use NPH to cover nocturnal tube feeds, and that works pretty well. So just kind of summarize these special situations. People with renal disease, they need less insulin, okay? Cut that total insulin dose down in half so you don't get low. People on glucocorticoids, remember, they're going to be high they're going to be high all day, but not overnight. And some patients do better with NPH on board. They need more bolus insulin. They don't need more basal. And sometimes NPH in the morning will cover those steroids in the morning pretty well. And people on internal tube feeds, remember that's going to be a little bit different there depending on what kind of tube feeding you're giving them. Okay, so again, whether it's continuous tube feed cycle, nocturnal, whatever kind of tube feed you're giving them, make sure you give them carb coverage for those carbs. Otherwise, their blood sugar is going to be running high. And then NPH we like a lot for the nocturnal tube feed. And I think that's all I got to say. I was going to go over COVID, but we're not seeing any COVID in the hospital now. So I don't think we need to go over COVID. If anybody has any COVID questions, I'll be happy to take them. But that's pretty much what we deal with on the inpatient side when it comes to sugar management. Any questions? Everybody's asleep. Huh? Yes. Yes. That's a great question. His question is a patient that comes in with a double-digit A1C, so really lousy control on a lot of insulin at home. So this patient's already insulin resistant and not controlled, okay? So at that point, okay, they're really insulin resistant. You want to break the resistance. Well, on the outpatient side, our insulin, the drugs we use in that scenario often will be a metformin kind of drug. And we love those GLP-1 agonists, the drugs like Ozempic and Trulicity help a lot too. Can't use them in the hospital. So now you're stuck with insulin, right? So we go very high on the doses. We do have people that are taking, 100 of Lantus twice a day, every 12 hours, and they're getting like 40 or 50 units of mealtime insulin too. But they are insulin resistant as they become healthier. But a lot of times the resistance will break and they'll require less insulin. But on the inpatient side, because you've only got insulin to work with, just have to keep going up on the dose. On the outpatient side, for a patient like that who's tremendously insulin resistant, we use U500. It's a very concentrated insulin. It's in a pen. It's 5 times as concentrated as regular insulin. So it works well because when they take one shot, they're getting like 5 units at a time. For each unit you think they're really getting 5 units. So a dose of like 20 units of U500 is like 100 units of Lispro. But that's on the outpatient side. In the hospital, you're just stuck with using a lot of insulin. Don't forget, a lot of those patients, when patients come in with double-digit A1C, sometimes they can go into ketoacidosis. Remember, there's ketosis-prone type 2 diabetes that we unfortunately see too much of. So a type 2 can go to DKA if they're really pushed. And that's where they have those double-digit A1Cs, and they've got the measurable C-peptide, but they're just insulin resistant. It's just not working. So that's where when they get out of the hospital, we like to get them on a regimen that's more physiologic for them. Try to break the resistance rather than just putting more insulin into them, increasing the dose on the outpatient side. We would lean heavily on metformin, sometimes pioglitazone, GLP-1 agonists, SGLT2 inhibitors, going a different route for those patients where insulin's just not working well anyway. Did that answer your question? Okay. Any other questions? You guys? Well, thanks a lot for listening. Good luck. Good luck. Thank you. Thank you. share. Stop sharing. I think I stopped sharing. Did I stop sharing?
Yeah, thank you so much.
Okay.
I can